Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Sarah Wood presents a case-based discussion on long-acting PrEP as a strategy to support PrEP persistence and reengagement. Dr. Wood is an assistant professor of pediatrics in the Division of Adolescent Medicine at the Perelman School of Medicine at the University of Pennsylvania and Children's Hospital of Philadelphia. For the full online educational program, Staying on Track, Strategies to Support PrEP Persistence and Reengagement, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Wood has to say.
So I'm going to talk about a case from my own practice. So this is an 18-year-old transgender woman who came to see me in my HIV treatment and prevention clinic. She had arrived to the United States a year ago seeking asylum, really due to persecution and violence based on her gender identity. When she had first arrived in the US at age 16, she was seen through a gender-affirming care clinic and was started on oral tenofovir M-tricytamine daily for PrEP, but had really struggled with adherence. After a time, she fell out of care. When she turned 18, she lost a lot of the access to the supportive systems that she had in terms of social work support, Department of Health and Human Services support, and because of that, also lost her housing and became homeless. She had re-engaged to care really with the goal of continuing her gender-affirming care. And her gender team clinic really thought that this is someone who might need a little bit of extra support to stay on PrEP, and so referred her to come and see us at our PrEP clinic. At this initial visit, we did our lab work and saw that fortunately, both our fourth generation HIV test and our HIV RNA were consistent with her not having HIV. She was immune to hepatitis B, and her hep C was non-reactive. She had a normal creatinine and normal LFTs. At all of our visits, we do triple site testing for gonorrhea and chlamydia. All those were negative. Her RPR assay for syphilis was non-reactive. And when we looked at hormone, that there was evidence that she had had some adherence to gender-affirming hormone therapy, noting that suppressed total testosterone and an estradiol level that would be out of the male sex at birth range. So this patient wants to restart PrEP today. And when we talked to them about the options, they were most interested in starting long-acting injectable cabotegravir, given the challenges that they had had in the past with adherence to oral PrEP and the challenge of being homeless and having difficulty with medication storage or maintaining a routine schedule. Now let's take a little bit of a broader view and think about PrEP continuum of care in adolescents and young adults. And so when we look at data from the Kaiser Permanente cohort, and we looked at individuals who were linked to PrEP from 2012 to 2019, this is over 13,000, close to 14,000 individuals. What we can see in this cohort that was overwhelmingly male sex at birth and about nearly half individuals identified as white, 52% of them had discontinued PrEP at least once. Now, the good news is that about 60% of those who discontinued restarted. But when we break down those data and look by age at the groups that are most likely to sort of fall out of our PrEP continuum of care, those 18 to 25-year-old patients are less likely to be prescribed PrEP than older adult patients. They're less likely to start their PrEP, meaning that you can get the prescription, but the patient still has to take the medication. And we also see that those 18 to 25-year-olds are significantly more likely to discontinue PrEP. And these data really suggest the need for tailored and intensive strategies to help support PrEP persistence in adolescent and young adult patients. So what are the system-level barriers for PrEP coverage? Well, we know insurance is a key driver of access to PrEP services. Insured patients are 4 times more likely to use PrEP services than uninsured patients. And there's many reasons for this. So some patients may not have insurance, but we also have the situation where patients may be underinsured. So they have insurance, but there may be a denial of coverage based on the plan. We know that there can be lack of knowledge about copays or the availability of financial assistance. And it's important to note that this is both on the side of the patients, but on the side of PrEP providers as well. So if we looked at the data from Washington State medical providers, nearly 500 providers who were aware of PrEP, 43% had frequent concerns about PrEP cost, and the majority feeling either very, 27%, or somewhat, 45%, uncomfortable discussing cost and insurance issues with their patients. And what about for our younger patients? Well, for young adults who, after the Affordable Care Act, are increasingly on their parents' insurance, there's the risk of confidentiality breaches if an explanation of benefits is sent to a parent's home for an adolescent or a young adult who is seeking PrEP services while on their parents' insurance. There can be complexity of billing, both understanding the coding processes and 340B pricing and coverage as well. And then in addition to thinking about the cost of the medication, we need to think about the cost of the routine care that's associated with accessing PrEP services. We know with our most recent 2021 CDC PrEP guidelines update, we are not just getting HIV fourth generation antibody antigen testing, but we're recommended to get HIV-1 RNA testing as well for routine screening for HIV infection during use of oral PrEP, that's at least every 3 months, or long-acting injectable PrEP, at least every 2 months. And there may be additional costs that can be passed on to the patient during those models of care. Now, our patient has come in, the case we talked about, and she wants to start now. We have her labs. And so, how much do we need to wait? And what are the benefits and what are the downsides of waiting? One other really great update in these 2021 CDC guidelines is a clear outline of the procedures that are needed to provide PrEP on the same day as the initial evaluation for some selected patients. So there's a lot of reasons to consider doing same-day PrEP. You can minimize that drop-off between the evaluation in which you determine that a patient is eligible for PrEP and that time to initial prescription of PrEP. It can reduce barriers to PrEP access and to delivery of PrEP. And really, for most other medical conditions where we see patients for preventative therapy, the standard of care is to provide same-day services. So if you think about our contraception model, we don't typically counsel, wait, and then start birth control pills a few days later. We really know that our best model of care is going to be able to wrap and encompass those services within a single visit. But there's some challenges as well. There can be system level barriers, including challenges with those payment options for both laboratory services, clinical care, and prescription. Sometimes we don't have that care continuity to be able to do the whole through line of services on a single day. And if you don't have an on-site laboratory or fast turnaround time to get your lab results back, there can be a lag between when a patient is given a prescription to get the labs done and the actual time where you get that HIV result back as negative, confirming that, okay, we're good to go to start PrEP. We also want to think thoughtfully about our patients and which patients we might want to think a little bit more deeply about. So certainly if there is a concern for renal disease, you might want to have to evaluate that a bit more to understand what the extent is and whether you need to tailor or think about different PrEP modalities. For patients who come in with the possibility of acute HIV infection, whether that's because on your screening questions you identify that they have symptoms of possible seroconversion or acute HIV, or they've had a recent non-condom protected, non-PrEP protected high-risk exposure, that might be another reason to have pause. And then finally, if we don't have the ability to follow up with the patient if there's an abnormal lab result. In this scenario, many of the times when we're doing same-day PrEP initiation, we know we're going to get that HIV test back later in the day or the next morning. So we might go ahead, do the prescription and say, we'll call you if your test comes back positive and we need to bring you in and have you not start. There's a scenario where you have no way to follow up with that patient. It's a question about whether same-day PrEP is really appropriate in that scenario. So we have fabulous real-world data that lets us know that same-day PrEP initiation can work quite well. In a study of PrEP candidates from the New York City sexual health clinics, and this is over 1,400 patients, 97% of their patients did qualify for immediate PrEP, having negative rapid HIV tests, no kidney disease, no Hep B infection, and no symptoms of acute HIV infection. But also from that same source of data, we can see the sobering number that of the 3% where there was delayed time to PrEP, only 35% ultimately started. And this really shows us that when we slow that process of getting PrEP to our patients, we may lose them in that PrEP care continuum. Moving to data from a pilot study of 100 patients in Denver who were given 30-day starter packs of PrEP at an STI clinic, 78% completed at least one follow-up visit, and 57% completed at least two, demonstrating that you can have great follow-up rates with same-day PrEP initiation. Moving to data from St. Louis, out of 334 individuals who received same-day PrEP prescriptions, 97% of those initiated PrEP and 78% continued for at least 3 months, again, showing that we can get to initiation and continuation in this sample. And then lastly, in Chicago, since 2012, 62% of the over 8,000 PrEP prescriptions delivered have been same day. And we've seen that there's a trend where annually you see increases of same-day PrEP starts. And this is really starting to be considered the default method of PrEP delivery in order to provide efficient, timely, patient-centered care. Once our patients start PrEP, we also want to put mechanisms in place to support persistence on PrEP. We're really only getting that long-term benefit of HIV prevention if we're not just starting, but we're supporting with our patients continuing. So we can think about ways we can support PrEP persistence at the stages of delivery, ongoing support, and in choosing our regimen as well. So from a delivery perspective, we can increase persistence by providing PrEP in settings where patients are already going for care. So thinking about primary care offices, thinking about STI clinics where people may frequently go in for testing. For our young patients, we want to deliver PrEP in youth-friendly settings. And what do I mean by that? That might mean having a decor or an environment of the clinic where youth faces and voices are seen, where we have front desk staff that are approachable, and that we have written materials or educational materials that are widely accessible, meaning that they are able to be understood and interpreted by people who might be lower literacy in terms of health literacy and have lower numeracy as well, which many adolescents do. We also want to think about providing PrEP outside of medical settings. So there's a lot of work, for instance, being done in pharmacist-delivered PrEP. We also want to integrate and co-locate PrEP with other services our patients are accessing. So for pregnancy-capable individuals, really integrating PrEP within OBGYN settings, integrating PrEP with gender-affirming care for transgender individuals, and integrating PrEP with treatment of opioid use disorder or Medicaid-assisted therapy for opioid use disorder for people who use drugs. And then when we start on PrEP, we want to provide ongoing support. Now that can be peer support and navigation, again, thinking about my people, the adolescents. That peer part is critical. So really identifying young people from within our neighborhood communities who can work within our clinics and provide that peer support. Doing computer and phone-based counseling, knowing that it may be difficult for people to come in office for the repeated follow-up visits. And there's a lot of data to support text messaging interventions as a really effective way to reach out and connect with people around both PrEP adherence and PrEP persistence. And then finally, when we choose our regimen, we want to do this in a patient-centered way. So we want to offer, as much as it's medically within the possible scope for this patient, the PrEP modality and dosing options that may work well for them, and offer extended pill supplies for those on oral PrEP. So we know that people aren't kind of getting cut off right at the end of that 3 months before their next HIV test. So let's talk about that question of PrEP eligibility by regimen. Well, our toolbox is growing all the time, and we now have a number of different options for PrEP. So the oldest regimen we have is daily emtricitabine and tenofovir, which is FDA approved and guideline recommended for all people, irrespective of sex at birth or gender identity. Now, daily PrEP, again, is sort of widely available for all groups, but on-demand PrEP or event-driven PrEP, which is dosed around the time of sexual activity, is off-label for men who have sex with men, trans women, and heterosexual men. But it is recommended by the International AIDS Society guidelines and the World Health Organization guidelines, the World Health Organization just for MSN, or men who have sex with men. And so there is some consideration of whether this is a great option or whether this is a feasible option for us, for some of our patients that meet those sex at birth characteristics. However, there's insufficient data to recommend on-demand PrEP for heterosexual women or transgender men. It's really not recommended given the lack of data on safe dosing and concentration in the vaginal compartment. And so really should only be considered if people are only having anal sex or only at risk from anal sex. Our second modality is daily emtricitabine, tenofovir, and alafenamide, which I think of as kind of being the cousin of our emtricitabine, tenofovir disoproxil fumarate. It's FDA approved and guideline recommended for MSN, trans women, and heterosexual men. But again, off-label for heterosexual women and trans men, unless they are at risk from anal sex only. And our newest kid on the block is injectable cabotegravir, which is FDA approved and guideline recommended for all populations, except in pregnancy where there's not yet sufficient data. And our last option, which is not available in the United States, but is WHO recommended, is the dapivirine vaginal ring. And that is an option that is available or recommended by the WHO in people who are female sex at birth. So let's look at that data for the efficacy of long-acting injectable cabotegravir. Well, the HPTN 083 and 084 trials compared long-acting injectable cabotegravir given every 2 months compared to daily oral FTC-TDF for PrEP. This was an international, multi-site randomized double-blind trial. It was a phase 2b and 3 for 083 and a phase 3 for 084. And what they found, although they had powered the study to look at non-inferiority of cabotegravir, ultimately long-acting injectable cab met criteria for superiority compared to daily oral FTC-TDF in both trials. So in the 083 trial, which enrolled over 4,500 men and trans women who have sex with men, there were 13 incident infections on the long-acting cab arm. And you can see here that some of those were on-time injections compared to those who were later determined to be infected with HIV at baseline. So the hazards ratio comparing the protective effect of cabotegravir to the protective effect of FTC-TDF was 0.34, so suggesting that the hazards of HIV acquisition were 66% lower in the cabotegravir arm. In the 084 trial of over 3,000 cisgender women, there were 4 incident infections in the long-acting cab arm, and 0 of those were on those who had had on-time injections. And in that trial, the hazards ratio for HIV acquisition comparing cabotegravir to FTC-TDF was 0.12, and that was highly statistically significant, demonstrating an 88% reduction in the hazards of HIV acquisition in the cabotegravir arm. Now, one question that I get a lot of in clinical practice is, do we need to do the oral lead-in for cabotegravir, or can we do direct to inject? Which is somewhat analogous to doing our rapid starts for oral PrEP when we have labs in hand and we know that someone is definitively HIV negative. So the oral lead-in dosing for cabotegravir can be used for approximately 1 month, really with the purpose of assessing the tolerability of cabotegravir. However, it is equally reasonable, safe, and effective for an individual to proceed directly to cabotegravir injection. And it's important to note that that oral lead-in is not intended to test adherence. In fact, many of the patients who come to me and are interested in switching over to an injectable method, that decision's really been driven by the fact that they're having some challenges with oral adherence. And so pushing through another month of oral medication may not be the best option for those individuals. So there's really no safety and efficacy data with LA-CAB PrEP without an oral lead-in. But when we look at the safety and efficacy data for long-acting cabotegravir plus rilpivirine, with or without the oral lead-in for the treatment of HIV, we can see that the pharmacokinetic data suggest that the oral lead-in is not necessary to achieve adequate CAB concentrations. And given these data, our approach in my clinical setting, and I think in many clinical settings, is to really have a patient-centered shared decision-making session to identify whether a patient wants the oral lead-in or does want to go to that direct-to-inject option. Another question that we want to think about for our patient who is on gender-affirming hormone therapy is whether feminizing hormone therapy may have an interaction with long-acting cabotegravir-based PrEP. And the good news is we have some hot off the presses data to show us that that's not an area where we need to be concerned. So there has been a sub-analysis of the 570 transgender women in the 083 trial that looked at, again, this trial was looking at that head-to-head comparison of LA-CAB versus FTC TDF PrEP. And in pharmacokinetic analyses, they found that there was no significant differences in CAB concentrations in trans women on feminizing hormone therapy, there's 30 in that arm, and those not on feminizing hormone therapy. And I think I was so thrilled to see these data come out because I think this is a really good reminder that LA-CAB should absolutely be on the table for our patients who are using gender-affirming hormone therapy with either estrogen-based or spironolactone-based products. So let's go back to our patient and talk about what we ended up doing. So as a reminder, we have our 18-year-old young trans woman who is here in the US for about a year post seeking asylum, coming back in to re-engage in PrEP today after having sort of fallen out of both the clinical PrEP system, but also a lot of the social support systems that were available to her in the US. And let's think about some other ways we can support my patient. We know that one of the biggest challenges she had with PrEP persistence early on was not related to her medical care. It was really related to asylee status, social stressors, not having significant social support in the United States, and homelessness. In the context of all of that, she had also had to drop out of high school, wasn't able to finish her education, and as is the case for many trans women, had challenges finding employment and finding the social and structural supports she needed to be able to have a good quality of life in the United States. So I always love to think about that big picture. And one of my favorite studies that's come out in the last several years is the Project LifeSkills intervention. And while this didn't look at PrEP specifically, it did look at HIV prevention outcomes for transgender young women. And the life skill intervention, it wasn't just an HIV education intervention. It was really a culturally specific, empowerment-based, group-delivered behavioral prevention intervention that went beyond just HIV and really thought about this concept of life skills in terms of ability to live your best quality of life through work training, through skills training, and through empowerment. When you compared the life skills group and the standard of care group, those in the life skills intervention had lower rates of condomless sex acts, and at least through the first few months of follow-up, had a fewer number of sexual partners. And I think this is really important data for us to also integrate into our PrEP delivery models, really emphasizing we need to think about the whole person, and that when we support particularly our adolescent and young adult patients through getting through those critical developmental stages, we're helping support their HIV prevention behavior and PrEP persistence as well. So let's get back to our case. We had our lab sent and confirmed our patient is negative. And she was reinitiated on PrEP with long-acting cabotegravir without the oral lead-in, so going with that direct-to-inject strategy. We realized that it would be really important for her to have that one-stop shopping model to get all the care she needs. So we integrated her gender-affirming hormone therapy into her PrEP services. But we went beyond just those medical interventions and worked with our social workers and our medical case management team to make sure that she had additional safety and life support services provided. So we worked with her to do safety planning around sex work. She was honest with us that that was happening in her life, and we wanted to make sure that she had lifelines. She had someone who knew where she was when she was working, and that she had safer strategies for engaging in sex work. We continued to do education with her on other ways to reduce her HIV risk as well. We provided housing support and were able to help her get into a shelter system that was specific for transgender women. And we provided educational support and linked with her state-based social worker, and were able to get her to restart high school. And I'm really happy to say that 6 months later, this patient has been adherent to their injectable PrEP. In that time, they have been coming in consistently for STI screening. They did acquire rectal gonorrhea, but we were able to treat that infection and really provide ongoing sexual health education. When this patient came to the US, they didn't know how to use a condom. They didn't know what lube was. And so we have really been starting with the basics and building on that at each visit to make sure she has the comprehensive health education to be able to make the best decisions for prevention. She's doing well in high school in an after-hours high school program, and has been linked back to a lot of the supportive social work services, both within our clinic and really within our state and city, to be able to support her as an asylee. And she's continued gender-affirming care, and that's not just been hormone therapy. It's also been things like wardrobe support, helping her find clothing that best match her identity. And also, learning how to size a bra, how to go bra shopping, a lot of those details of life that not just help with an internal sense of wellness, but when we know we can fully affirm people's identities and create safe spaces where all of their health needs are met, we're able to better deliver our PrEP services and keep our patients engaged in PrEP care. So what are some key take-home points from today? Well, when we develop our PrEP programming, really think about, for our adolescents and young adults, that whole adolescent approach. You don't want to just think about the regimen. You also want to think about how that regimen fits into school, work, and the other key developmental tasks of adolescents. For adolescents who are struggling with non-adherence to oral PrEP, non-daily PrEP options can be considered. With injectable cabotegravir, we can consider that direct-to-inject approach after having a shared decision-making discussion about oral lead-in versus no oral lead-in. We know that injectable cabotegravir is a safe and effective option for transgender women, and that integrating gender-affirming care and PrEP requires thinking beyond just hormone therapy and the other aspects of gender affirmation that can really create a whole clinic, whole person affirming experience for our patients.
Thank you very much to Dr. Wood, and thank you to our listeners for joining in. To get more from our program, see the link in the show notes. You can view a foundational video module on PrEP persistence, more vlogs featuring specific case examples, clinical thought commentaries from people using PrEP, and downloadable PDF resources for healthcare professionals to print and share. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.